the story. So in North Carolina, Home and Community-Based Services service about 58,000 individuals. They're either seniors or they are individuals living with disabilities or medical complexities. And Home and Community-Based Services under Medicaid is considered an optional Medicaid service. Other programs within Medicaid are considered mandatory, but home and community-based services are optional. And these individuals are on the screen can explain some of the different programs from one-on-one nursing to aid services provided in the home. Do we just want to go around the room and
Yeah, I would love to know I can see your name, but how long you've been doing this, and then share a little bit about, your clients and what makes your work so crucial.
and we'll start with Tom, and then Tom, you can pass it off to someone else.
Okay. Thank you, Congresswoman Ross. Well, my name is Tom Minowitz, and I've been with Beata now for 16 years. And I came from the golf industry of all places before I came to work for Beata because I wanted to make a difference in people's lives. I have a degree in agronomy, and then I went back and got a business degree, but I wanted to really make a difference in people's lives. And coming to work for a company like Beata, it allows me to although I'm not the one out giving the care, I'm working for a company that truly wants to help people and help people stay at home. I use the analogy a lot when I'm talking to folks about nobody grows up and says, boy, someday I hope I get to go live in a nursing home. Nobody wants to do that. So home care services is what allows us to help keep people at home. In my office, I'm in Shelby, North Carolina, Cleveland County, and we
I've been
cover
there.
Cleveland. Cleveland, Rutherford, Lincoln, and Gaston counties. So we're in the foothills just west of Charlotte. And our office, we focus on what we call ACSP, Assistive Care State Programs. So it's the Medicaid, the VA. My office happens to have a few private pay individuals as well, but predominantly it's the Medicaid and the VA folks. And for us, and Trip will touch on this as well, we work with the two main programs are CAP-DA, so Community Assistance Program for Disabled Adults, and then PCS, which is a similar program, but it's managed at the state level. An individual doesn't get quite as many hours per week. These services that they're getting are partnerships with the families that allows them to stay at home. So we're not providing anybody 24/7 care with a Medicaid. We know that it's less expensive than making somebody institutionalized. And a perfect example for us, I tell everybody, is we help take care of grandma who doesn't quite need to go to the nursing home, but can't stay by herself all day long. So we come in the mornings maybe, and we help get her up, get her dressed, shower if need be, help prepare a meal for her. Sometimes it's 2.5 or 3 hours a day. Sometimes it's 6 hours a day. And that allows the families to go to work part-time if that's what it is, or work full-time if they've got a team of individuals there. Very few, if any, of our clients live alone. Most of them have another family member there with them that's doing the care when we're not there. And so it helps us keep families together. And I like to use the saying, we want to keep people happy, home, and healthy. And so that's what we do. And I'll pass it off to Trip, who may be able to touch on a little bit more on the CAP side of things as well.
Good afternoon, Congresswoman Ross. I appreciate you taking time to be with us today. And I'm sorry my picture's not on, but I am actually in the car driving from one client to another appointment. And trying to be as safe as possible here. But I am in the same business or the same line of business as Tom is. We do state programs as well. And yes, the CAP program does allow, I think, more than just we are a partnership with the family, and it's a team to provide that client with the services they need to have a safe environment and able to live their life to the fullest at whatever stage they're at. I think one area that is kind of comes to mind for me is just around this whole idea of fraud and poor use of funds and home care is, people are just not, you're not getting the results for the investment that the people are making. And I think some of that, as I think about it, it's like I was talking with a financial guy and he said something to the effect of, if enough people say recession, then guess what? We're going to have a recession. And I think that's kind of what's happened here is enough people just say there's Medicaid fraud. And look, now people think there's Medicaid fraud. I don't know because I don't see it in the line of work we do. One great example of that is with the electronic visit verifications. And so we know our aides are at the client's house, what time they get there, what time they clock in. We know the tasks that are done. We capture the client's signature at the end of the shift, and we know they're when they clock out, they're at the house when they clock out. I think there's the government and us as partners. We've got guidelines and safety measures in there to ensure that service is being provided as prescribed or authorized, and we can prove it. And so I just don't see the whole Medicaid fraud being something that is, it may be out there, but I don't believe it's out there in home care like it's being reported right now. And I would say I've got great examples of services that we provide for clients, able to take them to doctor's appointments. We're able to take them to pick up their prescription medicine, when needed, through that CAP program. We also provide all the other things such as helping them with baths or dressing and grooming and that kind of stuff, meal preparation. So we provide services that these people wouldn't be able to have done without some help. And that's the business we're in. And I just I feel like we're going to have it's a hard time hiring people now. And if they cut the Medicaid funds, we're going to have to, we're certainly not going to be able to provide services to as many people and help as many as need to be helped out there. And so that's, from my perspective, I think that's probably would be a real downfall, for our country. So I don't know if I'm supposed to pass it along, and I can't see who else is on the call.
Tripp, I wanted to add one more thing as well, since you touched on the electronic visits verification. I know you can testify this, and probably every home care provider can testify to this, is that there are so many times throughout the week that our aides are there longer than what we actually bill for, because we are bound by that authorization. So if an individual is authorized for 18 hours a week, there's oftentimes that aide is there for 19, 20, 21 hours a week that we are still paying her because she's working, she's taking care of that person, but we're not able to bill for it. But like Tripp said, we can prove that they're there and providing the service based on the 21st Century Cures Act that President Obama signed into law, that requires electronic visits verification. And we've implemented that years ago. And we know they're there. We know they're providing the service. We know they're there when they leave. Everything works off of GPS with the geofences. So it's a great system, and it helps. I'm not going to say it eliminates all fraud, but boy, got to be pretty smart to figure out how to beat it with the systems that we're using. And Tripp, I know you can't really see what's going on, so I would pass it along to. I see Dina on there, so I'll pass it along over to Dina if she's okay with that.
Thanks, Tom. Thank you all for meeting today. I have been with Payada. I'm going on my 30th year at the end of this year with Payada. I started out as a home health aide and worked my way through college with Payada. I worked at the hospital as well, but I am an office director for the pediatric office of Winston-Salem. So I service Forsyth, Davidson, Davies, Stokes, and Rowan. I have licensure in other counties. just to partner like with Katie's office, if she can't cover something, like we can partner together, and cover that. So I think Tom and Trip did an excellent job, setting this call up. It, so with our peds, clients, if we're not there, our parents won't go to work. Our clients don't come home from the hospital. We're taking care of the sickest sick that can be taken care of. We're doing ICU work at home. So let me rewind that. We take care of skilled nursing clients where Tom and Trip take care of assistive care needs. We take care of skilled needs. My office does service home health day clients, similar to Tom and Trip, but ours are kids. So after school hours, baths, G-tube feedings, anything to help the family out, for them to be able to either continue to work a whole day, or to be able to go to another child's sporting event. I don't know what else I can say. It would be detrimental if our rates are cut, and also services, just for the population that we serve. I think North Carolina, Lee might have like better facts than me, but I know that right now our skilled nursing clients for direct Medicaid is over 500 alone, and that's not including managed Medicaid and tailored plan. My office also services IDD clients for the intellectual disability and developmental needs CAP program. So I provide respite services, nursing respite services for that. In the same building, Trip and I are in the same building, and Jill. There's a whole hab office, and I can't even fathom how many clients they have that they service as well. So they're providing basic needs for ADLs, but also those G2 feedings that in other states will qualify for nursing, but they don't here in North Carolina.
Instead of passing the baton, I'm going to speak up if that's okay. I'm Jennifer. I am in Eastern North Carolina, so I service east of 95, very rural area in some aspects. But what I like to do is when people say, "What do you do for a living?" I'm in home health care. They don't quite understand. So we service adults and peds. Peds from obviously 0 to our oldest client is in their 70s. No one asks to have a significant other, client, child, family member that either was born with a condition that makes them not eligible to be, a typical normal child. Or, as an adult, you had a stroke and it's left you as a quadriplegic or a paraplegic or something, and the families have to work. We get phone calls daily from our most satisfied clients. I need more nursing services. I'm going to have to miss work if I don't have a nurse. And we're staffing, if they're approved for 112 hours a week, we're staffing, 100. It's that they have to work to support their child, their loved one. We cannot compete with the local hospitals, the salary, maybe $40 an hour, $50 an hour they get at a hospital level. We can't do that. So we have to offer things like, the flexible work schedule. You can work Monday, Wednesday, Friday here. Where do you get to choose your work schedule? So cuts to that would be horrible because parents will have to stay home. Sons and daughters taking care of their parents will have to stay home. And if they do that, then they lose their job. And then it's a domino effect. And it's, then the system is supporting everyone. And it's just, to think about it from, you have a perfectly normal 1-year-old who was eating a hot dog and choked on it. And now they are in a vegetative state physically, like their mind is there so they can communicate to their loved one, but all because of a hot dog. Like nobody asked for that. Nobody asked for their son to fall into a swimming pool. And now, he's there and can communicate with his mom through his eyes, like through the adaptive technology where you can communicate, but mom has to go to work so she can still support him. It's not like that disconnect is there, like, oh, I need to go to work, or I can leave you. I mean, like, that's still her son. Like, she needs to work to take care of her son. And it doesn't, until someone actually comes and meets with those families and sees it for themselves, I don't think that hits home. And for us who are in the home every day and we see that, we want to do anything we can do, whether we're paying for a nurse and we're not able to bill for it, whether we are, you know, listening to their frustrations. I say we're a therapist a lot. We listen to the family's frustration about not having that support. Putting them in a facility would cost twice as much. So we're able to keep them home and save money. But yet at the same time, it's still not enough. And cuts would cut that, if that makes sense.
Yeah, and then you said you're from Eastern North Carolina. The chances that there would be a facility anywhere near where their
Correct.
family lives is, really remote. And so in addition to having it cost more, people in that vulnerable state would be cut off from their family. Is that right?
That's right. That's right. And the closest one, we do have one here in Greenville for peds only. And it's so small, and there's like a 3-4 year wait list for it. And then the closest one I think is like 2 to 3 hours away. So who wants their child 3 hours away where I can't work and then see my child all in the same day?
Right. Thank you so, so much for that. Thank you.
You're
It looks
welcome.
like we have three more people. We
I'm
have Katie, Jillian, and Bliss. Oh, did you have something else to say, Jennifer?
No, I was saying I'm sorry. I thought the time was up and I thought I would be quick. I'm so sorry. I apologize.
No, this is exactly what we want to hear. And we're recording this, so don't be surprised if we share it, because again, as I said at the top, people have no idea where that Medicaid money goes to if they themselves are not involved in Medicaid. So your stories are so important, and that's why we're doing this today. So,
And if I may jump in, so my background is long-term care. Worked in long-term care for almost 10 years and in 2 different states. So who I worked with, my clientele, was when you talk to them, if they could be anywhere in the world, it'd be home, right? They've had to sell all their possessions. They've had to liquidate everything to be able to afford long-term care. With working with private duty nursing, with CAP-C programs, things such as that, to be able to keep people in their homes for as long as possible. Certain skilled will cost more than private duty nursing. Some, it will cost less. The way that we can help the most, and the way that I see us helping most, Dina touched on it, Jennifer touched on it, is in facility. You can only do what you are able to do, what you're able to assess for, what your staff is able to assess for, and you can work in those parameters. If somebody poses anything outside of those parameters, you must send them to the hospital each and every time. It doesn't matter, because you're not able to assess them. At home, our nurses can do that. We can provide those assessments and prevent them from going to the hospital, because Medicaid is going to pay one way or another. You're going to pay for that hospital visit, and depending on what type of test they determine is necessary. We avoided that with a client alone just the other week with our nurses, I should say. They were able to keep him out of the hospital. He was very sick, he had pneumonia, but they were able to control and monitor that versus putting him in the hospital for however long. And again, like I said, I know just from 10 years on how important it is to be home and to remain home. And when they pay into Social Security and into those benefits, they should be able to utilize those. And not to speak, poorly on facilities, but a lot of times you're short-staffed. A lot of times you are struggling. You fight with the cost as well, depending on where those funds come from, if it's a Medicaid supported or private pay. And it still is kind of never enough. If we cut that, it's just extremely detrimental across the board for our nurses in particular. Just like Jennifer said, it's very hard to staff. It's hard when you can go to facilities and compete. But what we also say with doing that is, it's a 1-to-1 ratio versus a 1-to-16 or more, just depending on what that day holds. And that in itself is helpful with staff, because they do appreciate that. In that sense, it's not as stressful. But again, when you come back and say, well, these services are no longer, you don't meet the criteria. How do we know how to go about that? And that's one thing we're also fighting too, because I have clients with very similar conditions, but Taylor Plan is saying you're denied for this reason, but your managed Medicaid is saying, no, you're denied for this reason. It's saying, well, wait a minute, what makes heads or tails of this? How are we supposed to get these services? Because again, just as Dina hit on it and Jennifer hit on it, our families need to go to work. They need to be able to provide. So they're not continuing to use the system. They're using it for what's the most important. And I believe in criteria. I believe in thresholds. Absolutely, you have to. However, I think we're getting to a point where we're just saying no to everybody because that helps save it, right? That helps save the arguments when in reality we're spending more money because we're having to appeal or having to go through this over and over and over again. So
And Jill, I can kind of tap in. I'm so sorry to interrupt, but I would just love to share this. I know our meeting's about to end. This is one of our clients that everybody I'm sure can talk about. Like, this is just one of our clients. I live in the Greensboro area. This is our client Genesis. We actually took him home from the hospital. He has a tracheostomy in order to breathe, and he has a PRN mechanical ventilator in order to breathe at night. So not just anybody can come in and help. Unfortunately, since we brought him home probably a couple months ago, we have not been able to staff one night shift just because of staffing and not being able to compete with hospitals in the area. So we're already struggling with our Medicaid rates. So in order to, if he got cut, his mom stays up at night. She unfortunately would have to stay up during the day and at night if we weren't able to. So it's just, I'm sure each one of us on this call could tell you, in detail about each client that we have that needs services and why. But ultimately, it's about our clients and about their families just wanting to work in order to make ends meet. But if Medicaid is cut, we are definitely going to be not able to help as many people, unfortunately. So sorry to interrupt. I just wanted to at least throw his face out there. His name's Genesis. If you know any nurses in the Burlington area, please let me know. But yeah, we appreciate you so much for listening to us and today and hearing us out and hearing our stories. We definitely appreciate that, and we appreciate your advocating for Medicaid funds 100%.
Yeah,
Of course.
and I want to share one story too.
Can we let Bliss come in because Bliss
Yep.
hasn't gotten to say anything, and then I want to hear your story, Jennifer.
Absolutely. So I'm Bliss Pointer. It's nice to see all of you all. And everyone on this call, I think, has a little bit more knowledge on providing and the different acronyms. But I've been advocating for home care for probably 10 years now. And I just want to echo what everyone else is sharing and how important that educational piece is. If you've never seen care in the home, it's really hard to understand how essential these things are to those families. And, just recently we had a home visit with a local lawmaker, and I was able to see them come in and had no idea, all the things that come in with providing. And then with North Carolina having so many rural areas, these families may be traveling an hour to work every day. They're going to need a lot more care and a lot more time that is just not able to be provided right now, and cuts would just deepen that need even more. And I'll let Jennifer go ahead.
Well,
Jennifer to close.
Yeah, no, I was just going to share a story real quick. We had a
Yeah.
referral for an adult trach vent client. So like Katie's child, has an adult trach and a vent to breathe. The facility, mom was in a facility, daughter contacted us, wanted to bring her home. The facility was not able to provide because they have one nurse to 20 clients. We had everything lined up to go, and then the client passed away. So in the facility, because of whatever issue was, I'm not going to blame the facility, but there was an issue where the mother did not have one-on-one care and could not get the care she provided. Would that have happened if she would have gotten in-home care sooner, where the nurse could have been there for those hours and taking care? And so the facility was 3 hours away because there's not one for her mother. So she was in a nursing home near Western or somewhere else. I don't know where exactly. And she passed away last week. And it's just something that I have questioned myself. Like, if we would have moved sooner, would she have been, would she still be here today?
Thank you. Lee, would you like to share any final comments? You've been fabulous to put this together so quickly, in addition to the excellent, work that we've done together before. Anything that you would like to say for the group?
Well, thank you. I think the most important is that, home and community-based services fills a need, and if it's not there, then hundreds of thousands of individuals and families that rely on services at home won't be able to have access to that care. The whole Medicaid continuum of care, whether you're in the hospital, in a nursing home, in assisted living, in-home care, or in the community, it all needs to work together for the individual. And the individual needs to transfer from one to the other where the best needs for the services that they need in the time that they need, in the way that they want to need it, receive it. And it's all, governed by, what Medicaid is able to do in the various programs that they have. I heard uh, Deputy Secretary Jay Ludlam say that 20, 27%, $27 billion of federal funds come to North Carolina every year, and 98% of the funds that North Carolina receives from the federal government in Medicaid goes to programs and services. So if that $880 billion that is being proposed, um, if that really translates into some changes, then those changes will definitely impact services and programs because of the proportion of how much goes directly to either services or programs. And in North Carolina, there's 10.8 million people across the state. We're the ninth largest state in the union, and 20% of those individuals living here in North Carolina are 65 and older. And the individuals that are considered old of the old, which is 85% or older, not 85%, 85 years and older, that proportion is going to grow by 114% in the next decade. 86 counties out of 100 counties already today have more seniors than children. And so that's going to impact workforce as well. I think any work that you can do to help support and protect Medicaid is really important. So thank you for doing that. And we truly value that advocacy at the federal level for us.
Well, I want you all to know that I truly value what you do every day to make people's lives better. And so we are going to fight for you. It's not going to be a fun fight, but we are going to fight for you. And I want to thank you for putting a face on it, for putting an experience on it, because that's what we're going to have to do in order to protect Medicaid. And we're doing it all over the country today. And so you, in addition to what you do every day, you're part of this bigger thing. And so thank you so much. I won't ask for any more of your time at this point, but we may be back and we may want to visit. So thank you so much.
Thank you so much.
Have a good evening.
Thank you so much.